This is Dr. Marty Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, which was launched recently by the Center for Infectious Disease Research and Policy at the University of Minnesota. A component of this project are live webinars with global experts in the field of antimicrobial stewardship and antibiotic resistance. It's my pleasure to welcome you to today's webinar. It will be given by Dr. Lauri Hicks, titled Improving Antibiotic Use in Outpatient Settings. In 2015, Dr. Hicks became the director for the Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention, CDC. She is also the medical director for the Get Smart No on Antibiotics Work program, which aims to educate healthcare providers and the public about appropriate antibiotic use. She leads research on antibiotic use and resistance trends and serves as the campaign spokesperson. Globally, she also fostered CDC, European Union, and World Health Organization collaboration that has led to joint antibiotic awareness observances. In addition to all this, Dr. Hicks has published numerous articles in peer-reviewed journals, namely recently on antibiotic use patterns in outpatient settings, which she will be describing today. She also guided national antibiotic stewardship policy and guideline development. In addition to this, she's also an adjunct assistant professor of medicine at the Warren Alpert Medical School at Brown University. And the agenda for today's webinar is this presentation from Dr. Lauri Hicks, followed by time available to address your questions and comments. At any time, as a participant, you are welcome to submit questions and comments in writing via the WebEx chat box, which is located at the bottom right corner of your screen. When typing the question, please make sure to send your questions to all panelists, which will include Dr. Hicks and myself. Please be aware that all of your lines will be muted during the webinar while Dr. Hicks is presenting. So with that, I'd like to sincerely thank Dr. Hicks for joining us today and sharing her insights.
Well, thank you, Marnie, and thanks to CIDRAP for raising the profile of the problem of antibiotic resistance and for giving me this platform to talk about the role of antibiotic stewardship in outpatient settings. My job is to make sure that you walk away from this feeling compelled to include outpatient antibiotic stewardship into your activities. So I'm going to start this slide here that goes over our objectives for this presentation. I'm going to characterize outpatient antibiotic use in the United States, and specifically I'll share some data with you that will provide some context for why the outpatient setting is so important. I'll discuss why providers prescribe antibiotics inappropriately. There's been a lot of formative research on this topic. We'll discuss how to improve antibiotic use and what are the interventions that are most effective in the outpatient setting. And then lastly, I'll discuss national activities and policy recommendations to improve antibiotic use with a focus on what CDC is doing in this space. So where do we want to be? And I really consider this a definition for antibiotic stewardship, and certainly there are many ways to approach this, but we want to make sure that antibiotic stewardship incorporates activities and ensure that every single patient gets optimal antibiotic treatment. And that means whether the patient is being seen in a clinic, a hospital, a nursing home, we want this to be thought of as a patient safety issue. Obviously, the impact on antibiotic resistance is key, but we also want to address this as an individual patient safety issue. We want to make sure that patients only get antibiotics when they're needed, and when they are needed, we want to make sure that antibiotics are given promptly, and the right antibiotic, the right dose, and the right duration are administered. When you think about this across the spectrum of healthcare, we want to make sure that every healthcare facility, hospitals, nursing homes, outpatient clinics implements antibiotic stewardship activities, and that each and every provider is incorporating principles of antibiotic stewardship into their everyday practices. So I'm going to start off with a little bit of information about how we're measuring and characterizing antibiotic use, and this is specific to outpatient antibiotic use. Certainly there are other data sources for acute care and for nursing homes. So we use two CDC surveys called the National Ambulatory Medical Care Survey, or NAMCS, and the National Hospital Ambulatory Medical Care Survey, or NAHAMCS. And I'll share some data related to these surveys with you in just a minute, but I think it's important for you to know that these data are available publicly online, but there is a significant time lag in that the most recent data available is from 2012. We've also been working extensively with proprietary data that we've purchased. We've purchased data from IMS Health, which is a company that really has been collecting these data for the purposes of pharmaceutical marketing for over the years, but we've put them to good use for public health purposes. And we're looking specifically at antibiotic expenditures and population-based prescribing as well. And the population-based prescribing is based upon pharmacy transactions. This is really a census of antibiotics prescribing and gives us very granular information down to the county and zip code level in terms of how much is being prescribed and what is being prescribed. We also have used qualitative research to really understand the behavioral issues behind antibiotic prescribing and misuse of antibiotics, certainly surveys, focus groups, and in-depth interviews. And then quality measure data has also been very important. There are 3 quality measures related to outpatient antibiotic use. These are the HEDIS measures developed by NCQA, the Healthcare Effectiveness Data and Information Set. And the 3 measures include avoidance of antibiotics for upper respiratory infections in children, use of streptococcal testing for children prescribed an antibiotic for pharyngitis, and avoidance of antibiotics for adults with bronchitis. So just some examples of the data sources that we're using. Now let's get into the fun stuff, which is actually looking at the data. And this slide is not intended to emphasize that one setting is more important than the other, but I think it's really just understanding the contribution of the different settings to both expenditures and use in terms of human antibiotic use and expenditures. Now, antibiotic expenditures in the U.S. for human health care totaled about $10.7 billion in 2009. And over 60% of costs associated with the antibiotics were in the outpatient setting. That's that blue slice of the pie on your right-hand side there. And I think it's really important to recognize, we know that oral antibiotics are much less expensive than their IV counterparts or friends, and they're often used in the hospital setting. So this pie chart does not really adequately represent actual use of antibiotics. Data from other countries suggest that 80 to 90% of all antibiotics used in humans are used in the community or outpatient setting. And I just want to make that point just because I think oftentimes we don't recognize how much the outpatient setting is contributing to overall use in humans. Now, this is data from our IMS Health Exponent data set and gives us a really good overall picture of what's happening in outpatient settings in terms of the volume of antibiotic prescribing. These are data from 2014. We just analyzed this over the past few weeks. And we now know that in 2014, there were 835 antibiotic courses prescribed per 1,000 population in outpatient settings. So that's enough for every 5 out of 6 people to get an antibiotic each year. And that equates to 266 million prescriptions annually in the United States. So that's an incredible amount of antibiotic use. So how do we compare to other developed countries? It's not necessarily a pretty picture. In 2014, Sweden's antibiotic prescribing rate was under half of our rate, and they are still working on reducing use with a plan to get to 250 courses per 1,000. That's down from the 328 courses per 1,000 that they measured in 2014. So that helps to put things into perspective, right? So we see that we prescribe 835 per 1,000, and that compares to 328 courses per 1,000 in Sweden, more than double. When we compare ourselves to European countries in general, it's not quite as grim, but we still use a lot more antibiotics per population than Europe overall. So this one slide may just be my single claim to fame, just because it generates so much interest and discussion. Many of you have likely seen a version of this map, but if you haven't, I'm going to explain it in detail. And this map displays community antibiotic transactions per 1,000 persons in the United States. So again, I just mentioned we just analyzed the 2014 data, which are shown here. The overall antibiotic prescribing rate I showed on the previous slide was 835 per 1,000 persons. Of note, you can see on this slide there is quite a bit of marked geographic variability by state. If you look at the darker part of the slide, that's actually where the prescribing is highest. And just for a state-to-state comparison, we compare the highest state of West Virginia, 1,285 prescriptions per 1,000, to Alaska, the lowest state, 501 prescriptions per 1,000. Now, while this map doesn't really tell us what's appropriate and what's not, certainly this information has helped us engage states to participate in antibiotic stewardship efforts. And we also have been looking at the factors associated with the geographic variation we have seen here. There have been a lot of questions about this whenever we have shared this map. What I think is important to know is that when we look at other data sets that provide information on antibiotic prescribing for conditions that don't warrant antibiotic use, so for example, bronchitis, we know that prescribing for conditions that don't warrant antibiotic use is higher in the South and this part of the country that is darker on this map compared to other regions of the country. So we know that there is some evidence of more inappropriate prescribing in the South. However, there are probably a lot of other factors playing a role here. And we've been looking at some of the county level factors that appear to be associated with higher antibiotic use. Obesity in particular is one that stands out. And in fact, if you put this map right up next to the obesity map, they look almost identical. And certainly persons with obesity and diabetes may be more prone to infection, but we have to question whether the disruption in the microbiome that is being caused by more antibiotic use could be contributing to obesity in the U.S. population. And so this work that is being done on the microbiome is really fascinating right now, and certainly I encourage you to follow the work that is being done by Dr. Marty Glazer and others that suggest that there may be a role in obesity. So here's a slide that shows you a little bit more information about the diagnoses leading to antibiotics. And I just want to explain that this is not the same data source as the previous slide. This pie chart is based upon data from CDC's NAMSIS and NAHAMSIS surveys that I mentioned earlier. And here you can see the diagnoses that lead to antibiotics in doctors' offices and emergency departments. And of note, you see that bronchitis and viral upper respiratory infections collectively account for 10% of all antibiotics prescribed in these settings. And we know that antibiotics are not indicated at all for these conditions. We also believe that there's a lot of opportunity to reduce antibiotic prescribing for the most common condition that leads to antibiotic use, sinusitis. And then that's followed closely by ear infections and pharyngitis. And while I'm not showing you any data on antibiotic selection, we see a lot of fluoroquinolone and macrolide use for the common conditions for which the first-line recommended agents are most commonly beta-lactams, amoxicillin, and amoxicillin clavulanate. So next I'm going to discuss some work we recently have done to establish national targets for improving antibiotic use. For those of you who are familiar with the National Action Plan, you may already recognize some of this material that I'm just going to present to you. In the National Action Plan that was released by the White House, by 2020, significant outcomes of Goal 1 include establishment of antibiotic stewardship programs in all acute care hospitals and improved antibiotic stewardship across all healthcare settings. That includes outpatient settings, and then reduction of inappropriate antibiotic use by 50% in outpatient settings and by 20% in inpatient settings. What I want to call your attention to is that right side of the slide right now with the bars. We did an analysis looking at the opportunities for reducing unnecessary outpatient antibiotic prescribing and found that a full 50% of outpatient antibiotics for acute respiratory conditions are unnecessary. And then we looked at other conditions as well, using a geographic approach for some of them to understand where are the opportunities for improvement. And we saw that about 15% of the antibiotics prescribed for those other conditions are likely unnecessary. So when we wrap that up, that is the culmination of that study, and the results from that study is on the left side of your slide, and you'll see the 70% versus the 30%. Using a very conservative approach, we came up with this: at least 30% of outpatient antibiotic prescriptions, I would say specifically in doctors' offices and emergency departments, are completely unnecessary. And in this particular data set, that amounts to 47 million unnecessary antibiotic prescriptions each year. So an incredible amount of antibiotic use that's totally not needed. So I know I've been sharing a lot of, I would say, not so great news. I want to mention that we have made some progress. When we look at antibiotic prescribing for children younger than 15 years of age, comparing data from the early 1990s to 2007 and 8, we found out there was about a 25% decrease in antibiotic prescribing for pediatric visits. And this was really evidence of behavior change, because this was visit-based prescribing. Similar decreases have been seen in other studies. Study looking at data comparing 2010 all the way through 2000 to 2010 found a decrease of about 18% in pediatrics, but it's important to note that while we've seen large improvements, or I would say fairly significant improvements in pediatrics, we have not seen the same kinds of improvements in adults, and particularly in older adults, we've actually seen an increase in prescribing. So what do we know about outpatient antibiotic use in the United States? We know that there's a lot of outpatient antibiotics use in the U.S. compared to other countries. We know that there's a lot of geographic variability within the United States. Some of that we think is explained by unnecessary or inappropriate antibiotic use. But we also have a lot of information about antibiotic prescribing for respiratory conditions, and we know those are the conditions that often lead to unnecessary antibiotic use. And then there is some information that we don't know. And this is really important to understand, that there are opportunities to improve antibiotic use in other settings, like dental offices, retail clinics, and urgent care centers. But we really don't have the data yet that we need to provide specific recommendations for those settings. So that's something that we're going to be working on actively. So now that I've shared some data, I really want to discuss why this is happening. And here are 3 common hypotheses to explain why providers prescribe inappropriately. For the sake of time, I'm going to keep this really brief. The first one, lack of knowledge of appropriate indications. Actually, this does not seem to be playing a major role. When we have interviewed providers, they usually are familiar with national guidelines for common infections. Knowledge can sometimes be a barrier, but it's really not the central problem. Fear of complications does come up. Providers are uncomfortable with diagnostic uncertainty. That's understandable. And so some providers cite prescribing to avoid a patient developing an invasive bacterial infection. However, we have learned that to prevent one case of lower respiratory infection, approximately 4,000 patients would need to be treated with an antibiotic, with 4,000 patients with an upper respiratory infection. When we think about this, we have to really be thinking about the risks and the benefits. We now know that the risk is much higher for a serious allergic reaction or adverse event like Clostridium difficile colitis. So we need to be communicating about the balance of the risk and benefit to the patient when there's this concern for complications. However, when I look at the slide, the last one is the overriding favorite and the biggest concern that providers raise when they're talking to us about the reasons why they may prescribe when antibiotics either are not needed or when they may prescribe an antibiotic that is not necessarily the first-line recommended drug. They say that patient and parent pressure and the issue of patient satisfaction is paramount and has become such an issue because obviously patients and parents can go online and actually report out their experiences, and this can really have an impact on providers. So I love this quote, and I was actually listening actively to this interview, and this is one of the quotes that we stored for perpetuity. It just really helps explain the crux of the problem. And I would say this is not always the case. Not every practice is necessarily kind of like a business in terms of providing care for patients, but a lot of practices are really under pressure to maintain their patient population. And so we got this quote: "We as doctors are business people. We're no different than running a shoe store. If somebody comes in and wants flat shoes, you don't sell them white shoes, and if you do, they get upset. You can convince a patient, look, if I were you, I wouldn't take this antibiotic, but patients in general don't understand that concept of not taking it if you don't need it. And if you don't give it to them, they don't come back to you. And in fact, we're hearing from urgent care providers that if they don't prescribe an antibiotic, because there are so many other options for urgent care, that they might just go to the urgent care right down the street." So how can we help physicians do the right thing, to only use antibiotics when needed and to keep their patients satisfied? We have learned that patients are still satisfied and parents are still satisfied if they don't get antibiotics, if certain needs are met. And this is really critical here. In particular, patients and parents really want an explanation as to why antibiotics are not needed. And this is, you can say something like, this is clearly a really nasty cold, and they want their visit and the reason for their visit to be validated. So you can say, yeah, this is a miserable, nasty cold, but antibiotics are not going to help here. Or you have a chest cold. Sometimes the patients hear the word bronchitis, they automatically assume that antibiotics are needed. We also hear that patients and parents want positive recommendations. This means that they want to know what they can do to feel better. Say, take ibuprofen, rest, drink lots of fluids. And they also want to know what to do if they don't get better. What if they don't get better or if they get worse? In particular, they want to know what to do specifically. Should they call back? Should they come back? What kinds of opportunities for follow-up does that provider offer? So I'm going to move on to talk about interventions to improve antibiotic prescribing. And because I was talking about the interaction between the patient and the provider, I really want to start with the point of communications training. And I just remember in my medical training, we did not have communications training related to these very common scenarios. In particular, I don't remember any communications training around how to handle interactions around antibiotic use. What I remember is communications training around very breaking difficult news to patients, talking about cancer diagnoses, for example. But I think communications training in this particular area would be extremely beneficial, and there's quite a few studies that have recently been published to that effect. So one thing I would say about this is that these trainings hit on very similar points to what we just talked about. Understanding patients' expectations, providing an explanation for what is going on, and providing treatment to help the patient feel better. And what we also have learned is that the effects of the communication training appear to be sustainable over time. If you're interested in specific resources, there are a couple of nice publications that are recent, one in Annals of Family Medicine in 2013, and one in Lancet in 2013 as well. That was a study done by Little and colleagues. Let's talk a little bit about the wait and see approach. There are a couple studies about this. One is from Spiro, published in JAMA in 2006. Another more recent study, De La Posa, Avad in JAMA Internal Medicine in 2016. We know that in patients who are given, or parents who are given this option, 62% of children with a diagnosis of presumed acute otitis media with a wait-and-see prescription did not fill it, compared to 13% of children with immediate prescriptions did not fill it. So clearly there is a difference there when offering the wait-and-see approach. And there are certainly other examples. I think this is a good option for patients with ear infections as well as patients with sinusitis. Clinical decision support is another great option. There have been some studies that have shown that it's effective for reducing antibiotic prescribing for acute bronchitis. For pharyngitis, we know that it can help improve antibiotic selection for pneumonia. There are some important considerations, though, with clinical decision support. We believe that print and electronic tools are likely equally effective. So if if there are barriers from an informatics standpoint, print tools are certainly an option. The main issue is that tools need to be used to be effective. We need to make sure that they're part of the workflow, that the workflow makes sense to the provider. In one study, clinical decision tools were only used in about 6% of eligible visits. So we need to know how to incorporate this into the workflow to make it effective. I have to say that this next intervention is probably one of my most favorite of all time. And I would also mention that a lot of the work that has come out recently related to antibiotic stewardship and prescribing improvements in outpatient settings, I really feel are some of the most sentinel studies in this field. And this one by Meeker and colleagues really describes a very simple intervention. Basically, a poster is placed in an exam room with a provider picture and a commitment to use antibiotics appropriately. They did this wonderful randomized control trial where they just used this very basic principle of behavioral science, the desire to be consistent with a previous commitment that you've made. And in this study, just by simply posting this on the wall in the exam rooms, there was a 20% absolute reduction in inappropriate antibiotic prescribing for acute respiratory infections compared to controls. This is almost a no-cost intervention, and it had a major impact. So we would like to see more of this happening in outpatient settings. Audit feedback has been shown to be a very powerful motivator. Providers need to know when they are not performing well. And when we talk to providers, they always point the finger at either other providers or other practices, and they often don't recognize that they may be playing a role in this inappropriate antibiotic use problem. There are a number of nice studies that have been published recently. Meeker also published a nice study in the British Medical Journal, their open journal recently on this. There's an example in there about peer comparisons and how they sent out emails periodically to each prescriber comparing his or her antibiotic prescribing rate with those who had the lowest rates of inappropriate antibiotic prescribing. That is really playing on the behavioral aspects of inappropriate prescribing, and providers were told that they were not top performers. Academic detailing is a form of one-on-one education. I'm not going to go into details here, but can be very helpful in terms of educating providers about appropriate use. I want to spend just a moment talking about how CDC is addressing the gaps. There are certainly a number of different groups and agencies working on this issue, but CDC really is playing a central role in this effort. We have communication efforts. We have a Get Smart about Antibiotics Week coming up. We have Get Smart and Know When Antibiotics Work, so we have a campaign. We're working on expanding CDC's public outreach campaign. We have just hired a new PR firm, and we'll be updating the Get Smart campaign. We're also working on targeting our messages based upon the data that some of the data which I've just shared with you. We're using data for action. We're working on engaging retail and urgent care clinics and other facilities in collaboration with our partners. Pew Charitable Trust has been a key partner for us to determine the best approaches to measuring antibiotic use. Implementation, we're expanding antibiotic stewardship to outpatient settings across the country in a number of different ways. One example is we're working with CMS-funded networks, or the quality improvement networks, to recruit outpatient facilities to participate in outpatient antibiotic stewardship. We're also working with a private payer, Anthem, and the American Academy of Pediatrics to incentivize stewardship at the individual provider level through their chapter quality networks. So this is how we're working on really reaching every single provider. Our state-based activities. We're expanding support for state and local public health to implement targeted antibiotic stewardship interventions across all healthcare settings. I think it's important for you to know that CDC is funding over 30 states to implement antibiotic stewardship activities, and 18 states are currently working in the outpatient space. There are a number of great examples. Illinois has a wonderful campaign, Precious Drugs, Scary Bugs. We have other states that are actually using data to provide individual report cards to their providers so that they know how they're performing relative to their peers. And then we're starting to work on some new partnerships. We've obviously had many important partnerships over the years, but we're also engaging nurses, pharmacists, dentists, and other healthcare providers in outpatient settings to implement antibiotic stewardship practices. And lastly, we're developing policies and recommendations for antibiotic stewardship in a number of settings, including the outpatient setting. And I'm going to share a slide with you that is basically a sneak peek of what is coming soon. We will be publishing on November 10th the core elements of outpatient antibiotic stewardship. The 4 core elements are listed here, and I want you to note that this is a little bit scaled back or simplified compared to the core elements for hospitals and the core elements for nursing homes, both of which include 7 core elements. And lastly, I'm going to finish off with just a little bit of information about CDC's Get Smart campaign. Some of you may be familiar with our campaign, and we really have had activities spanning several decades now. We launched the National Campaign for Appropriate Antibiotic Use in the Community in 1995, and then the Get Smart Know When Antibiotics Work campaign was launched in 2003, and that really had a focus on improving antibiotic use for respiratory infections in children and adults in doctors' offices. And we really were focused more on pediatric providers and parents of young children. We have expanded this focus, and we continue to work on expanding this focus. And as I mentioned earlier, we're not only focused on the impact of improving antibiotic use on antibiotic resistance, we're also focused on improving the quality of healthcare and preventing adverse events, such as C. difficile colitis, as I mentioned on this slide. Lastly, I'm going to finish off with mention of our upcoming annual observance, which is Get Smart About Antibiotics Week. It's going to be held November 14th through 20th. We have a number of social media events planned for that week. We welcome all of our partners to participate, and if you don't have any information or not aware of what you can do during that week, I encourage you to go to our website and visit our website, www.cdc.gov/GetSmart, and look at the information available there about participating in Get Smart Week. And just so you know, we did just record a patient, and I would say a partner call for our Get Smart About Antibiotics Week partners, and that is recorded and will be available online. And just to state that without our partners, we would really not be making much progress. And so we rely upon all of you to help us get the word out about the importance of improving antibiotic use. And with that, I will finish and open the floor to questions.
That's terrific. Thank you, Dr. Hicks, for your very insightful presentation. We have had several questions that were submitted during your presentation, and I will also mention to the other participants, if you hadn't had the opportunity and would like to submit a question, please do so with the chat box there at the lower right-hand portion of your screen. One of the questions, Dr. Hicks, is you described some of your data analysis, and some of that data was proprietary data that you mentioned the CDC purchased, the IMS data set.
Yes.
Is that data is it available to the states, to clinicians, to the public, or is it not, or will it become available?
So the great news, that question is perfect, because we are in the process of incorporating our outpatient antibiotic use data onto the Patient Safety Atlas, which is a CDC website that provides specific data on antibiotic use and antibiotic resistance. Currently, right now, it has a lot more of our surveillance for antibiotic-resistant infections and multi-drug resistant infections. But in the future, as of Get Smart Week in November, we will be posting antibiotic use data. Now, we are not able to share it at the level of granularity that we have obtained. We have the data down to county level. However, due to difficulties in interpreting county level data, we're only going to be posting state level data. So you will see on the Patient Safety Atlas statewide antibiotic prescribing rates basically prescribing per 1,000 population, and you have some ability to compare yourself to the national average. You'll also be able to look at specific classes of antibiotics. And in the coming years, I'm hoping that we'll actually be able to share more granular information on this site.
A second question, you mentioned that some of the prescribing practices had declined in children with respiratory tract infections, but yet in the older adult population, those prescribing practices have increased. Do you have any insights into why that's occurring? Should that be potentially a target for clinicians, practitioners trying to make a difference here with their stewardship programs?
Absolutely. I think that the adult population is extremely important, and even the older adult population is potentially, even more important, because in terms of the volume of antibiotics used, the youngest population, so the under 5s and the over 65s, are the populations that lead to them, or that use the most antibiotics. It's understandable. Certainly that makes sense. In the older adult population, we're just in the process of working on getting access to data. We don't have nearly as much data on how antibiotics are being used in that population as we do for the pediatric population. We also don't have as much information about what's happening in long-term care as we do in the outpatient settings. One thing that we're really interested in understanding in particular is antibiotic use and antibiotic. There's a lot of antibiotic use in older adults for asymptomatic bacteriuria. And so we would like to better understand, which patients should be eligible for testing and make sure that those guidelines are implemented, as well as making sure that when test results come back, that they're acted upon appropriately. Again, I think that we don't have all the answers yet to why the older adult population is seeing an increase. I suspect some of that has to do with the fact that we just have a growing older adult population with more comorbidities and complex medical conditions.
Does that also lend itself to the potential to start to include more and more point-of-care diagnostics at the outpatient setting?
So I think that is certainly one facet to addressing this problem. When I think about all the things that we need to do to improve how antibiotics are used and address the problem of antibiotic resistance, improving how we're using existing diagnostics, as well as incorporating the innovation and new diagnostics into practice is definitely going to be an important piece of this puzzle in terms of how we're going to solve it. I think we're starting to see some of that innovation and really starting to see some of the opportunities for new diagnostics and rapid diagnostics that will give us answers very quickly at the time of the visit. And I think that's the key. A lot of the diagnostics that we have been using in the past were really not timely enough to inform the visit and the decision making at the time of the visit, but that's going to change.
So taking you back to your outpatient use data, are you also collecting urgent care clinic data or retail pharmacy clinic data, or is anything being done to also collect these types of information?
So there are some data sources that we're looking into that have the ability to delineate what is being prescribed in a retail clinic versus an urgent care clinic versus a traditional doctor's office. We just started analyzing those data. We are currently using a data set called TruVan Market Scan. It is claims data, so we're using basically the diagnostic codes that are being recorded in the claims data and then looking at prescribing for conditions that commonly lead to antibiotic use. I can't give too much away because we're still in the early stages of the analyses, but what I can say is that a very large proportion of visits to retail clinics and urgent care facilities lead to an antibiotic prescription. We think that there's a lot of opportunity, especially in urgent care, because there are so many independent providers in urgent care, whereas in retail clinics, while there's still quite a bit of opportunity there to improve antibiotic use, those providers are subject to more of an algorithm-based approach to prescribing.
Additional question that was submitted discusses some of the core elements that are coming out, and one of them is the ability to monitor antibiotics prescribing. What type of approaches can providers, or I guess at the practice level, would be an approach where they can actually monitor their prescribing practices? Is this something that it will be more at the private insurance level or at the private practice level?
Yes, and I think it's a really important point, and certainly any type of tracking requires time and energy, so we want to be cognizant of the resources available in individual practices. When the core elements are published, you will see that we will have specific recommendations for what individual providers can do as well as what can be done at a clinic level or a health system level to track antibiotic use in outpatient settings. I think when we're thinking about clinicians that don't have a lot of time or resources to dedicate to tracking antibiotic prescribing, one approach is actually just performing a self-audit and looking at reviewing your own charts and understanding, what's the frequency of prescribing for conditions that don't warrant antibiotics, for example. And so that's what we're recommending for providers in settings where there may not be a lot of resources. In settings where there are more resources, we're encouraging more of an electronic approach to monitoring antibiotic use.
A question that, taking it back a little bit maybe to the older adult and the increase in prescribing patterns, is you had mentioned the prevention for asymptomatic urinary tract infections and providers trying to prevent further sepsis. Do you feel that some of that is promoting actually the antibiotic utilization, and that some of there needs to be potentially a campaign within this area?
So a really important point is that we are working on both a sepsis campaign as well as refreshing our Get Smart campaign, and we're working with the same PR firm to accomplish both. And the reason why is we don't want to be sending mixed messages, and we don't believe that they really should be in conflict. In an ideally, when we're performing good antibiotic stewardship, we're also making sure that patients who might have sepsis get treated early and often. And in that scenario, we're not really going to be looking at trying to reduce upfront antibiotic use. What we're really encouraging there in that particular situation is reevaluation after the patient has been started on antibiotics. Of course, we do not want to jeopardize the patient safety by withholding antibiotics from someone who might have a septic-like picture. However, I would say in the outpatient setting in particular, the problem really is with the common respiratory conditions that are typically fairly mild, that are just really a nuisance to us and prevent us from going back to work or prevent our kids going back to school. And so it's really coming up with strategies to reduce prescribing for those conditions that lead to a lot of unnecessary use.
You mentioned that some of the CDC initiatives is through partnerships and then also data acquisition. Have you partnered with other large healthcare organizations in addition to, depending on where your data sets are coming from, and do you see within those data sets, are there different usage of antibiotic patterns, whether it's an HMO or a private practice?
So we have partnered with a number of large healthcare systems, and in fact, one of our most long-standing partnerships has been with the VA. And we've been looking at antibiotic prescribing practices across the entire VA system. On the outpatient front, we have learned that even though we know that there's a lot of geographic variability in what we see in the VA actually mirrors what we see nationally, what I shared with you today, when we look at clinics and individual providers, there is actually quite a bit more variability in individual antibiotic prescribing by provider than there is at the clinic level. So we know that there's opportunity to identify outliers even within a large health system and target them for intervention. And I would say that we're working with a number of different health systems. We think that that's a great approach to scale up antibiotic stewardship implementation. We're working currently with University of Utah, Intermountain Healthcare, as well as their VA. to really scale up implementation and evaluate the core elements that we're about to release. So I would say yes, the answer is yes, and we have a number of other partnerships with health systems. I saw here the Kaiser Permanente is in the chat, and we are regularly in conversations with Kaiser as well.
Well, thank you, Dr. Hicks. I want to thank you for your time today and your discussion with some of the CDC's initiatives and campaign, and obviously for all your research in this area. I'd like to conclude then the webinar, which I will mention was recorded and will be available at our Antibiotic Stewardship Project website. That's located at www.cidrap.umn.edu/ASP. In addition to this webinar, I also want to make our participants aware that we also just recently posted a policy update and review that pertains to the outpatient antimicrobial stewardship practices. This is available under the ASP content tab in the upper right-hand corner, located under policy updates. So thank you, Dr. Hicks, for your time, for these insights, and I also want to thank our participants today for all of your very insightful questions. We appreciate your support.